Morning.
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 Happy New
How's-
Year.
Yeah, really. I think everybody has Snowmageddon on the brain.
Oh yeah.
It's like I'm looking at the feed and I'm like, this is a little light for this time right before meetings. Sorry, Chris. It has been a very, very rough month for me. Um, my sister passed away
Mm.
January 2nd, and the funeral was the 9th, and so that
Oh,
whole week was
no.
toast.
Sorry to
Um,
hear that, Craig.
Sorry
That's
to hear that,
terrible.
Greg.
Yeah, Greg. Sorry to hear that.
Appreciate that.
Yeah.
She had been sick for a while, so it's always unexpected, but not really a surprise. Yeah.
Yeah.
And then my dad on Martin Luther King tripped over one of the dogs and broke his hip, and he had to have hip replacement surgery this week, and he's just got placed in a rehab facility down in Henry County
Oh.
yesterday, and so I am at home. This is not my normal gig, normal digs. And as soon as this meeting's over, I'm going to Henry County. So and
Oh,
try and beat the snow back, which I will, but it's
Oh
just one
my
of the.
gosh. Well, when it rains, it pours, doesn't it?
Yeah, I
my
know.
goodness.
That's a lot.
Where's he live over there, Craig?
I'm sorry. My dad lives in Campbellsburg.
Campbellsburg, does it?
Yeah, that's in your neck of the woods.
That's our back door. Yeah.
So so yeah, he's going into the Newcastle facility.
Okay. Yeah. I think it's signature over there too, isn't it?
I'm not sure. I'll figure it out when
They're
I'm.
all signature. Signature of Carrollton, signature of Newcastle. They're signature of every town they're in. It's a big parent company. They bought most of them up in rural Kentucky. So,
Yeah,
yeah. But I've never heard anything bad about that facility at all. So,
good, awesome. And then one of my cousin's sons, who's a little bit more handy than I am, is coming down to help install handrails and stuff throughout the house. So
Oh, that's nice.
yeah,
Yeah, that's a brutal 2026 for you.
so I've been a little preoccupied. Sorry.
Yeah, understandably. Well, hopefully the rest of the year improves. How long's your dad going to be in rehab, do they
I
think?
have no idea. Knowing him as being as stubborn as he is, as short as possible. I'm
Yeah.
surprised he's not trying to walk out right now. So
so he
Well,
just
that can be a good thing.
he didn't have a surgery that repaired the fracture. He got a hip replacement.
yeah, entire side of his hip,
That's
all,
probably
all
he
new.
will fare better with that than he would some type of a repair.
Yeah. Let's see, what do we got? I got me. So just for my edification, who is listed as human resource admin?
Linda Coleman.
And, okay. And so you're going to be the new official voting ad rep?
Um, I think, isn't Amanda going to be on,
I don't know. And
Chris?
I think so.
I think so. Chris, you're muted.
So Amanda was hired recently and she's replacing Corba.
Can you guys hear me?
Yes.
Yep.
Okay. Just making sure. Thank you. Good morning.
Morning. Hey, Joby, can you turn on the camera? Thank you, sir. Sorry, state law.
No, it's okay.
And who is Edith?
My name's Edith, and I'm from Mendon. I'm
Okay.
filling in today for Amber.
Okay, great. So, Mr. Secretary, have you been keeping track of who's coming in? Six, I have 12.
Hey, Edith,
Yes.
Mayor Adams from Carrollton, how are you doing?
Good. How are you today?
I'm fine. It's been a while.
It's been a long time. I was wondering if I was looking at the same person over there.
I just retired from one, so you've got me down to one.
Okay. Well, it's nice to see you again.
Good to see you. You're doing okay?
Yeah, I'm doing just fine. Yeah.
Good, good.
I have 12 as well, Chairman.
Cool, thank you. So I will go ahead and call this meeting to order. And we just heard officially that we have quorum. So I will move now to the next item on the agenda, which is approval of the agenda that was sent out in the link. If there's no changes, I'll entertain a motion to approve the agenda.
So move.
Mayor Adams?
I'll second.
Paul? All right, great, thank you. All in favor, please say aye.
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 Any opposed? Okay, next item on the agenda is the approval of minutes. Those are also part of the share folder. Is there any discussion or suggested changes for the minutes?
I'll make a motion to approve those as well.
Okay,
Second.
thank you. All right. So Mayor Adams and Terry. Any other discussion? Hearing none, all in favor, please say aye. Aye.
Aye.
Any opposed? Awesome. Next item on the agenda is the financial report.
Okay, I'm not seeing the button to share my screen.
It should be the green button.
Oh, yeah. Well, that would have been too easy. Right there in the middle.
Yeah, it's all good.
Okay. I think you might have to give me permission, Chris, or whoever's running the.
Avery, can you give her permission, please?
Yep, she should have permission.
Okay.
Okay. All right, now I got to get the document up. Okay. Can everybody see that
Not yet.
coming? No? Let me try.
No.
Maybe I needed to share again after I had permission. Okay, how's that?
Got it.
All right. So this is the financial report from Jefferson Health Plan for the first 6 months of the plan year. So I'm going to focus on the column on the far right, which is the year-to-date numbers. And year-to-date, of course, we had $0 within Jefferson Health Plan. All of the reserve money is in the legacy account, if you will. And we had some investment income this first 6 months of this plan year, about $1,300 worth. Accruals, that's another way of saying premiums. So this is how much the plan has been funded by everybody contributing their monthly premiums. So a little over $3 million. So total revenue of $3,050,448. And then we have had about $2.3 million in medical claims, $392,000 in pharmacy claims. So total claims paid out about 2.7 million. Large claim reimbursement fees, that's another way of saying stop loss premiums. And the same with the aggregate protection fees. That's the aggregate stop loss. So your total stop loss premium for the first 6 months was about 418,000. And then the administrative fees for Jefferson Health Plan totaled about 32,400. TPA fees, that's what you pay to MedBen to administer the plan, about 154,000. Broker fees, that's Cheryl Morgan, about 42,000. PPO fees, that's the access fee that we pay for some of the plans to access different networks, about $1,200. So total TPA fees of about 197,000. The PCORI fees were 1,573. So total expenses of about 3.3 million, which leaves us with a deficit of about $283,000 for the first 6 months. Now, I do want to add that there are about $98,436 in premiums that are owed for the first 6 months that had not yet been received from Jefferson by Jefferson Health Plan. So once you take that into account, the deficit is that much less. So any questions?
Well, I have some general additional information. So I just checked the main accounts this morning, and we have roughly $2.1 million in Heritage, is the old legacy account. So we have that. There's about $27,000 sitting in the old HRA account, which is what we use to take care of those individuals who could not qualify for manufacturers programs for the drugs that we banned from the plan. There's about $27,000 sitting in there. There's about $9,000 sitting in the old Fifth Third account, which is basically now the holding fund for the interest for the $247,000 CD that we have at Fifth Third. So not all of our stuff is on this report. There's also probably about $20,000 in additional expenses since 7/1 that the board has to pay for that is not covered by the medical premiums, such as the fee to the ad district for all the great things they do for us, and then our insurance, directors and officers insurance to make sure that we're covered if something were to happen to the board itself and not necessarily a medical expense. So there's some things that are out there, and this is a good report, but I think we need to try and find a way to add some additional information to it or have a supplemental. Because this is, it's great to know month ending and year to date, but it doesn't mean anything if I don't have the budget with it. If I don't know how I'm running compared to where we thought we'd be, like how much did we budget for this? I can't, I can see we're negative cash flow, but I can't see how we're running as far as where we thought we'd be, as an issue. The other thing is now that we're with Jefferson, the stop loss is going to be a little bit different. I don't think we're going to be getting checks from Jefferson to plug back in like we were with the old stop loss. I think we're just going to, they're going to forward that money and cover our bills, and then they're going to take into account that deficit in the next budget. That's my understanding anyway. Am I wrong in that?
No, that's correct.
Okay.
Yeah.
So in the past, when we had people who would have high claimants, we would eventually get a point where we would start getting checks back that we could put back into the account to offset. And so now we're not going to get that, but what we're going to get instead is Jefferson Health Plan will just cover the deficit for us. And then they'll roll that into the next year's premiums, which with us having, well over $2 million sitting in our old accounts, we get to make a decision if we want to backstop that or not. And just depending on what medical inflation and everything else is doing and where we all are with our budgets, I think that would be a great conversation for us to have.
I have a quick question. So we're a $283,000 deficit. You add in the 98,000, I think you said, in premiums that haven't been paid for the year. From that budget, where did we go over? Was it the medical claims? Was it pharmacy claims? Do we know where we exceeded in our budget?
I don't have that answer off the top of my head, but when we get into the MedBen report, you'll see where your cost drivers are. And you'll see that you've had some additional high claimant activity this year compared to last year, but there are some factors that kind of make that a little less impactful for the rest of the year, and that is your high claimants have met their specific deductibles, and so we're going to be getting more money back in stop loss through Jefferson Health Plan for the rest of the year. And also your high claimants all have improving risk profiles. So we're optimistic that we're gonna, improve as the year goes on with respect to that deficit. So I don't think anybody needs to, hit the panic button or anything like that. It's fairly typical for us at the, during the first part of the year to see the plan take more hits than it does the second half of the year, just because people haven't hit their stop loss yet. And when we get into Brooks' report, you'll see that MedBen's actually projecting that on a per employee basis, you'll end the year down 6%. So I think as we work through the detailed reports, it'll kind of explain some of what you're seeing here in the financial report.
So am I to expect Jefferson Health Plan will send us checks like the old stop loss, and then they'll take that into account in the next renewal?
Yeah, so they're not going to send checks, but it'll all be done within your account at Jefferson Health Plan.
Okay.
So when you do stop loss reimbursements, it'll be put into your account that they have.
Okay.
But it
This
will be
is
taken
new.
into account in the next renewal.
Yeah, no, this is just new. I mean, it's a
Yeah.
different way of doing it. And we knew there would be some different presentations. But at the same time, I think we're all happy and comfortable with the information we were getting in the past.
Mhm.
I think I know I would like to see something similar.
Yeah, I think we can work on that. Just to try to, and pull in those pieces of information that you referenced, Craig, and the premiums that are, not reflected here that will eventually be paid. I mean, nobody's ever not paid their premium.
Right.
So, yeah, we'll work on that for the March meeting.
So Lisa, given that this Jefferson Health Plan is new, and this is one of the first reports we're getting from it 6 months in, and knowing there's money other places prior to going to Jefferson, does this $283,000 deficit today alarm you?
No,
Okay.
no, not at all.
Okay.
Okay, any other questions on the financial report? All right.
Thank you much.
Mhm.
Next is the agenda items. We just did the financial report. Next would be the 6-month plan review.
Can everybody see that okay?
Yes, ma'am.
Okay. So this is your 6-month plan review. We have claims from July through December and then annualizing them out through the end of the year, where we anticipate you'll end up if you run the same way you have the first 6 months of this year. Lisa alluded to a couple things, but you've had more large claimants in the first 6 months of this year than you did the prior year. You've also had about $418,000 in stop loss reimbursement so far this year because of your large claimant activity. So we don't want to annualize all of the individuals that have met your specific stop loss deductible into the numbers for the rest of the year. So when we take that out and annualize your claims, we're projecting you to be down about 10% from where you were last year. On a per employee per year basis, you've had a slight increase in your enrollment. We're projecting you to be down about 15%. And then when we add in your fixed costs to your claims, we're projecting you to be down about 6%. So a couple things that I want to point out, your average trend over the last several years is well below what we typically see for groups, which is anywhere between 5 to 8% year over year, and you're beating that trend. So getting into the details of the report, if we look at just time period to time period, so up top we have your aggregate numbers, and down below we have it broken out on a per member per month basis, which will take into consideration the increase that you've seen in your enrollment in the first 6 months of this year. So on a per member per month basis, your medical claims are down. Your pharmacy claims are up just a little bit. We'll talk about your pharmacy claims here in the next several pages, but they're up about 13% when we do factor in your fluctuation that you've seen in your enrollment. So gross, your claims are only up about 2% overall. When we take into consideration the reimbursements that you've received, you're actually down about 13.5%. Okay, looking at some of the cost drivers within your plan. So you can see here, again, these numbers are based on a per member per month basis. The claims are from July through December. We're comparing it to the last year, the last 6 months, which is in the red block here. And then we're also comparing you to our municipality and public benchmark. So pharmacy claims went up on a per member per month basis from last year. You're still below our benchmark or beating our benchmark there. Inpatient claims dropped off. You had 11 inpatient admissions, but the number of days that your members were in the hospital decreased pretty significantly from last year to this year. So that's a factor there, well below our benchmark. Your outpatient claims have increased so far in the first 6 months of this year. Your two largest claimants are cancer diagnosis, and a lot of their treatment for cancer and chemotherapy is performed on an outpatient basis. So that's a consideration when we're looking at this number. These numbers are also gross numbers, so do not take into consideration any of the reimbursements you've received this year. Your office visit claims went down closer to our benchmark. Your office visit utilization stayed pretty steady. You saw a slight increase just across the board on all of your office visits. And then post-acute care went down. If I look at medical and pharmacy combined, your claims on a per member per month basis is right around $632. And last year you were about $618. So again, about a 2% increase, but our benchmark is $695. So again, still beating our municipality and public benchmark. Okay. Just looking at utilization on this next page. So this is just your medical claim utilization. Just a couple things that I wanted to point out on this page. It stayed pretty steady from time period to time period. You had 577 members have a claim. We paid and processed 5,194 claims. And then if we're just looking at the average cost of your medical claims, it's right around $427 compared to our benchmark at $461. Looking on the next page, this is breaking out your different coverage tiers within your plan. So we're looking at employee, family, employee spouse, and then employee child coverage. Over to the right-hand side, you can see on a per member per month basis what the coverage tiers are costing the plan right now. Your employee spouse coverage tier is the highest on a per member per month basis. They also have the highest prospective risk score, which is pretty common when you're looking at employee spouse coverage and the average age that category is. Also, a lot of your high claimants were employees or spouses on your plan. Okay. And then your top hospital providers, St. Elizabeth continues to be your most utilized provider. Different facilities are broken out by their tax ID numbers. So you'll see Florence and Fort Thomas listed. But again, they continue to make up the majority of your utilization. They're also the top paid provider, followed by Children's Hospital. You had 38 members go there, 93 claims. So total facility claims this year, right around 1.3 million. If I look at last year, same time period, you had about $1.1 million in total facility spend. So you did see a little bit of an increase there. But St. Elizabeth was also your largest or top paid provider. Last year, Good Sam also fell into that category. Children's was a little bit further down the list, but similar in the number of people that went from last year to this year. Just the cost was different. Okay, inpatient admissions, you had 11 total inpatient admissions. The cost is well below our benchmark. You can see the average length of stay for your admissions. The longest was for your medical admissions. You had 4 medical admissions, 5 surgical admissions, and 2 maternity admissions so far this year. Okay. And then outpatient imaging, the majority of them were MRI and CT scans. The cost was well below our benchmark for both MRI and CT scans. And Children's Hospital was the top paid provider from an imaging facility standpoint. Okay. And then emergency room utilization, you can see over to the left-hand side about $2,300 per ER visit, where the plan picks up the majority of that. The most common diagnosis that was seen in the emergency room was for a cardiac disorder. And then the most common avoidable diagnosis was for back pain. You did have one individual that we considered a frequent flyer that went to the emergency room 6 times. And I have her diagnosis on another screen. I will pull it up here in a minute. So of the visits that we considered potentially avoidable, your group only had about 8% of them considered potentially avoidable. Our benchmark is 12.5. So below our benchmark when it comes to avoidable visits, but we did see that one individual that went to the emergency room 6 times. Again, the majority of your ER visits were for cardiac disorders, followed by GI disorders, which is pretty common, what we typically see from emergency rooms. Here you can see the one individual that went 6 times. And then if the visits that we considered to be potentially avoidable went to either an urgent care or an office visit, your potential for savings would have been about $3,700 for the first 6 months of the year. Last year, your avoidable visits, your potential for savings was about $3,500. So pretty similar in regards to the savings potential for avoidable ER visits year over year. Okay. Looking at your large claimants so far this year, you have 9 individuals that have met half of your specific deductible. So that's who we identify as a large claimant on your plan. Again, you have 9 individuals. 4 of the 9 have actually hit that $85,000 specific deductible amount. And you've also fulfilled that one-time bucket of liability, or that $150,000. That's your aggregating specific deductible. So now you're getting reimbursements back. Anybody now that goes over $85,000 in claims, you're going to get reimbursements back from the stop loss carrier. And Lisa had mentioned that everybody that falls onto this list, their prospective risk score is actually going down, which means the risk, it forecasts their risk for the 12-month period immediately following the end of this report period, which typically means that claims are going to also go down for these members. It's based off of claims that come through. It's like an AI score that they assign to each individual based on what we can see from claims. So that's typically a good indication. But again, anybody that hits that $85,000 threshold now until the end of the year, you will receive reimbursements back. Okay. So you did have about $75,000 more in large claim activity this year. Your total large claimants added up to about 819,000, where last year you were about $741,000 in large claims. Okay. And then page 20 is just graphs of everything I just went over. Page 21 are your utilization metrics on a per 1,000 basis. A lot of numbers on those page, but this is so you can compare yourself to our municipality and public benchmark. Your actual numbers are on the following page. So just a couple things that I wanted to point out on here. You did see a few more ER visits this year than you did the prior year, but you also saw about a 15% drop in your urgent care visits. Office visits, as I mentioned, stayed pretty steady. You also saw that increase in enrollment. So typically you're going to see a slight increase in office visits because of that. Substance abuse had the highest percentage change, but it went from 2 visits last year to 10 visits this year. And then looking at some additional preventive visits, mammograms, you had 30 mammograms this year, and you had 14 colonoscopies, which was an increase from last year. I had mentioned the decrease that you saw in the number of days for your inpatient stays dropped pretty drastically. A lot of that stemmed from the maternity inpatient days dropped and the NICU days dropped. Okay. Chronic conditions, we're still continuing to see claims for the individual that's diagnosed with end-stage renal disease, followed by chronic kidney disease, you can see there, and liver diseases. So those are all related to one another. Congestive heart failure and cancer. So these are your top 5 chronic conditions, and these are based on a per member per year basis. So taking claims so far this year for those conditions and annualizing them out through the end of the year, what you may anticipate looking at from a cost standpoint. Going to jump. Okay. Behavioral health dashboard. We know of 96 individuals with a behavioral health diagnosis, which is down about 8.5% from last year. Also, the cost decreased for individuals that have that diagnosis. The majority of people fall into an age range of 10 to 14, followed by 40 to 44. Most people are seeking treatment from an office visit and have a diagnosis of mood and anxiety disorders. You didn't have any inpatient admissions based on behavioral health diagnosis, but you did have 6 ER visits for behavioral health, And I believe, if my memory serves me right, that is your frequent flyer. Okay. Cancer diagnosis. We know of 13 individuals on your plan that have a diagnosis of cancer. The average age is right around 51, and the majority of them are employees on your plan. Most people are seeking treatment at St. Elizabeth, and the majority of their claims are performed on an outpatient basis. Again, going back to that outpatient costs going up last year to this year. And then your diabetes dashboard, we know of 69 people that have a diabetes diagnosis. 65 of them we received medical claims on. 66 of them we have a pharmacy claim for. The majority of them have type 2 diabetes. And the medical costs for individuals that had diabetes actually this year went down, well below our benchmark, went down from last year. Pharmacy costs, though, went up from last year to this year. And your top medications are Mounjaro, Ozempic, and Jardiance, which is what I'm seeing pretty much across our block of business. Okay. Looking at your well living compliance numbers, this was updated on January 7th. You can see annual wellness exam compliance is about a 48%, cholesterol 67, colonoscopy 51, mammogram 62, pap smears for members 21 through 29, you're at a 50% compliance, and over 30, you're at a 53% compliance rate. Okay. And then just a few more things that I wanted to point out in the pharmacy section. So your pharmacy claims did go up this year on a per member per month basis, up about 13%. 86% of the scripts being filled were generic medications, which is good. You saw a pretty big spike in the cost for Mounjaro, but just looking at your top 5 medications, the majority of them are GLP-1 medications or diabetic medications. You do have Eliquis and Lonsurf listed here. Lonsurf is a chemotherapy.
Hey, Brooke, can I just interject here? I just wanted to mention that you implemented the Rescribe program for international sourcing of some of these drugs that are hitting the plan pretty hard. And that only started in December. So we're really not seeing the impact of those savings yet, but we will as the year progresses.
Yep, absolutely. Okay. And then from a utilization standpoint, you did have an increase in utilization, number of people that received a script this year and the number of scripts that were filled. But again, you also saw that increase in employees and members on your plan. Okay. And then you can see here on the next page, the largest dollar increase from the prior period. The biggest jump you saw in your plan was on Mounjaro. This is pretty much what I'm seeing across the board. Last year, Mounjaro was ranked 5th in regards to cost. This year, it's ranked 1st, followed by Ozempic and then Jardiance. Okay. And then same with your therapeutic classes, your diabetic therapies had the biggest jump when it comes to cost. And that is pretty much it. The next few pages are just therapeutic classes that your group's seen. Any questions?
So the drugs that are included in the Rescribe program, is that some of the top
Yep,
five, or are
yep.
they going to be affected
Those
in
diabetic
that manner, or
therapies are,
is it a different drug?
I'm sorry.
I just didn't know if it was in those top 5 or 10 drugs would be affected by the rescribe, or was that something else?
Yep, nope. Those medications, especially Manjaro, Jardiance, can be accessed through rescribe. It's the exact same medication.
Okay. So is it
It's
just
just
going to
shipping from
default?
Canada.
Okay. And I mean, anyone that's on that, is it going to default to that program?
It
Like,
has, no, you have to make it voluntary because it is international. You cannot require them to get their medications through there. So it's a voluntary program, but we're seeing about a 78% acceptance rate for members switching over to that rescribe program.
okay. Because
And
I mean,
anybody
once
who's on one of those drugs should have been contacted by
Mhm.
Rescribe. They get a phone call and an email. So
Okay.
there's outreach being done. It's not up to the
Yep.
member to get in touch
Sure.
with Rescribe.
And there's incentive to do that, correct? Because it'll be no cost to them,
No
correct?
cost.
Exactly.
Yep.
Okay.
And convenience because it comes directly to their home.
All right, great. Thank you.
Mhm.
It's really a win-win situation. We've had great success with it.
When you say they get a phone call and an email, does the employer that get the phone call and the email, or does the actual patient?
Actual member.
Okay.
Yep.
Yeah. And there were some flyers that were sent out. If anybody needs those flyers, we can get them over to you again. It's always a good idea to let the employees know that, hey, if you get contacted by Rescribe, it's a partner, that we're using through MedBand to get drugs for you at a lower price point, so that they don't think it's a scam or something. They know the name MedBand, but they don't know Rescribe.
So, excuse me. I believe we shifted vendors that are helping people with HRA claims. Was RX Help Centers now? Is it Integra now?
It's the BPP program through MedBand.
Okay.
Mhm.
And is Integra running that one?
Yeah, so between MedBen RX and Vintegra, they're combined. So there's outreach from our employees, but we work with Vintegra is still the processor behind the scenes.
Okay. Just I had an employee who went through the RX Help Center process, and it was a little bit involved. And now when Vintegra took over, or the new BBP program took over, they said this employee no longer qualified.
Yeah, we're working on that one, Craig. We think that there was a disconnect in the transition between RX Help Centers and the BPP. So
Okay, great.
we should be able to get that one resolved pretty quickly.
Cool. And then one note, when we went through the 6-month plan, it showed like $418,000 in stop loss reimbursements. Those are not showing up. I'm just making sure those are not showing up on the report that we're getting from Jefferson Health Plan. If you take that into account, along with the missing or yet to be paid, I guess is the way to say it, yet to be paid premiums, we're like 233 to the good. And
well, I think those stop loss reimbursements that you're seeing on page 1 of the 6-month plan review, that's a projection. Now, the actual numbers in one of the columns, I think, are overstated. Brooke, I was going to ask you about that after the meeting. The 400 and some odd dollars in stop loss reimbursements are what we will project for the individuals going out for the rest of the year. So, yeah, we'll get clarification on that. If you look at the aggregate report in the last couple of pages of the plan review, you'll see that there's just some minimal stop loss reimbursements so far this year. And there are some timing differences between the MedBen report and the JHP report too. So you'll see the stop loss reimbursements reflected on the JHP reporting going forward, but sometimes there's a little bit of a lag.
Okay, fair. Anybody else have any questions? All right. Hearing none, next item on the agenda is benchmarking.
Okay, so let me share my screen again. Can everybody see that?
Yes.
Yeah.
Okay. So this is a comparison of your Plan 9, which is the plan that most employees are on, to a couple of different benchmarks. One is the Kaiser survey, which is a national survey of a few thousand employers. And the other one is the 2024 Kentucky Government Benefits Survey. That's a survey that Cheryl Morgan does every year in conjunction with CAFR, the Kentucky Public Human Resources Association. And so what you'll see is that on Plan 9, your predominant plan, there's no deductible. And out there in the marketplace, across the country, most employers are at an average single deductible of almost $1,900 and almost $5,100 for family. In the Kentucky survey, you'll see no deductible is the standard, and that is because a lot of Kentucky governments are doing exactly what you do with your plans 9, 10, and 11, the reference-based plans where it's all copay based. And then on Plan 9, you've got the $25 primary care office visit copay, which is just a little bit better than the national benchmark and right on par with Kentucky governments. For specialists, it's a $35 copay, which is better than the national norm of $45 and the Kentucky norm of $45. So you don't have any coinsurance since it's an all copay plan. The national benchmark for that is 80/20, and same for Kentucky governments who have coinsurance. The standard is 80/20. Your emergency room copay is currently $250 on Plan 9. Kaiser does not report that benchmark, and that is exactly where the Kentucky benchmark is, $250. We're showing RX option A here because that's what most people are on. You have two different pharmacy options. Option A has flat dollar copays, $0 for generic, $30 for tier 1, $75 for tier 2. And you can see that that's either on par or better than the national benchmark and the Kentucky benchmark. In terms of your out-of-pocket maximum, you're at $9,200 and $18,400, single and family, which is the maximum that the federal government allowed this year. The Kaiser survey is at $4,400. Kentucky's at $9,100 and $18,200. The Kaiser benchmark for that is lower, but you're much more likely on a traditional plan with the deductible and coinsurance to hit that than you are on a plan like your Plan 9, where only copays accumulate toward that out-of-pocket maximum. So that is the benchmarking on plan design. Any questions on this page before I show you the benchmark for cost? Okay. So this is a comparison of your per employee cost, what we're projecting for this year, compared to, again, the Kentucky Government Benefits Survey, and then the Mercer survey, which is another national survey of both public and private entities, a few thousand employers in that survey. And you'll see that you're below both of those benchmarks at about 16,800. So Kentucky is at 17,400 and Mercer's at 17,500. Any questions? Okay. Mr. Chairman, you want me to move into recommendations?
Yes, please.
Okay. All right. So no decisions need to be made on these today. We're just kind of getting these on your radar, and we'll revisit these at the March meeting. And we divide our recommendations up into health and then pharmacy recommendations. So on the health plan side, you saw in the 6-month plan review that you have had some ER utilization that is a little bit concerning. You had the one person with 6 visits or more, but you have also had 8 people who went twice, 2 people who went 3 times, and 2 people who went 4 times. So we would recommend that you consider increasing your ER copays for any of the plans that have an ER copay. There's one plan where everything goes to the deductible by $50, just to, make it a little less convenient, I guess, to go to the ER, but still not bankrupt anybody who actually has a need to go. And then we always recommend that you adopt the federal maximum on the out-of-pocket. And for next year, that will be $10,600 single and double that for family. So that would be on plans 9, 10, and 11. And then on the pharmacy side, some generics are what we call high-cost generics. And currently, MedBen is, MedBen and Ventegra are pulling the tier 2 copay for those high-cost generics, but not all of the plan documents make that clear. So a couple of the documents, SPDs or SBCs, say that all generics are at the generic copay. So we would like to amend the plan documents to codify what's happening in practice, which is high cost generics are going to pull a tier 2 copay. So it's not really a change in your plan. It's just making the documents reflect what the practice actually has been. So
Can I ask a
those are our
question?
recommendations. Any questions?
Can I ask one?
Of course.
Hi. So I'm new to the plan here. So I just had a question in regards to increasing ER copays and then amending the plan. I'm sure this is the case, but I'm just curious, has there been previous education around, the actual cost for ER visits as opposed to going to an urgent care? Is that something that's been identified in the plan or something that we could include just to make people more aware?
If it has been done, it's been on a group by group basis, but
Okay.
there certainly are flyers that we have that kind of educate people about, where you should go for which kinds of situations. And so those, if you're interested in having something like that, we can certainly provide that. And, Cheryl Morgan and Mebane are always happy to come out and do employee educational meetings. And that's the kind of thing that we can talk about in those meetings. But great question.
Thank you.
Mhm.
I have a couple questions.
Sure.
The person that went to the ER 8 times, I would guess it's obvious that they're using that as their primary care physician. But do we know why the chief complaint of all the other? I mean, how many of those were legit and how many weren't? So we can kind of determine, is it being abused as a clinic?
Yeah, Brooke, I think, was that a mental health issue?
Yes, it was. So the individual that went 6 times went for mental health issues. There weren't any visits that were considered non-emergent, but there were visits from a severity standpoint that fell into like a low category or non-severe. But they were all still paid as emergent ER visits. So you do have some visits falling into those lower severity categories, which we typically don't like to see.
It's been a long time since we made any changes to any copays, so it's just something to think about, just trying to provide steerage to the right kind of treatment for people. I mean, most of the time you can go to an urgent care for or your primary care doctor for whatever is ailing you, but sometimes the ER is necessary. Either it's, when urgent cares and primary care offices are closed, or it's truly an emergency. But I mean, the idea isn't to keep people from getting care. It's just to make sure that they're thinking about it before they go to the ER.
And what is a current copay for ER?
It's $250 on plan 9, which is the plan most people are on.
And what is the current out of pocket on plan 9?
It's $9,200 for single. So a lot of the plans in the marketplace have ER visits go to a pretty high deductible.
$1,000, some of them.
Yeah, plus co-insurance.
Even more
And
than
then
that.
some even have deductible co-insurance and a copay every time you
Yes.
go.
Yes.
So your plan is pretty generous on the ER copays.
Yeah.
Can you go back on screen? I think I might have had another question. I'm trying to jog my memory what it was. Okay, moving right along. I forgot it. That might be the only.
Okay, any other questions or comments on the recommendations or the benchmarking?
I just keep an eye on the specialist office visit. I mean, I think it's great that we're less than the benchmarks, but I don't want to be too far less than the benchmark.
Yeah.
So, if one day they start to push towards $50 and $60, we're going to have to take a look at that.
Okay. Yep. Agreed.
Yeah, I see specialist copays on ACA plans that are $75, $100. So yeah, that's not a bad thought.
Okay, then I'll, Mr. Chairman, I'll go on to compliance.
Thank you.
Okay. Oh, guess I didn't open that one, sorry. Ah. Okay, can everybody see that?
Yes.
Okay, so we talked about the out-of-pocket maximums, what the recommendation is there, and that's really an Affordable Care Act provision that limits how much a plan can impose in the form of either deductibles, co-insurance, or copays on an in-network basis. And the feds are allowing those to be raised next year, so those would be $10,600 single and double that for family. The PCORI fee is an ACA tax that was supposed to have gone away in 2019, but got extended an additional 10 years. And it comes due every July. And this July, it'll be $3.47 per covered life. And they've announced that for next year, it'll be $3.84 per covered life. And Michelle will take care of that when the time comes. ACA reporting is coming up. I'd like to remind everybody this time of year, the deadline for filing with the IRS is March the 31st. And the deadline for providing employees with forms is March the 2nd. However, you don't have to provide copies to employees anymore. You're allowed to just provide them upon request, but you have to let them know that they can request a copy. What we found is that most employers are continuing to provide them to employees because they ask for them. Their tax preparers ask for them sometimes. And so, maybe just easier to go ahead and provide them. Just to remind all the entities, you do have to submit electronically to the IRS now if you are filing 10 or more forms. And if you need help doing that, because it's not easy to do, we have a vendor who can assist you. So just reach out to Mike or Michelle or me, and we can put you in touch with them if you need help with that. So that is compliance. Any questions?
Okay.
All right.
Right. That concludes the listed agenda items. Next on the agenda is announcements and reminders. The note says our next meeting is March 20th via Zoom. So please get that one on your calendar. The only other item I have for the good of the order is for our next meeting. This is kind of like, just go ahead and add this now. I would like an agenda item to discuss what to do with the legacy account and in possible investments, because $2 million is great and we are getting interest on it. But I think there's some opportunity to possibly do a little bit better in some secure investment platforms, like with either KLC or one of the other local banks. And so would like to have that discussion. It was not on the agenda for this for this meeting, so we can do it in March. Does anybody else have anything for the good of the order?
Craig, I have one question to Lisa, I reckon. On those recommended changes, you said we would revisit that in March. If we decide to do that, is that when it needs to be done? Is there a certain time of year you need to do this or have it done by a certain time? Or is that just when you want to revisit it?
We'll just bring it up again. If as long as MedBen has, 30 days notice or so, it's all good. Our recommendation would be to make any changes effective on July the 1st when the plans renew.
That part makes sense. I got you.
Yeah.
Okay, thank you.
Mhm.
And for those who missed it, because I did at the beginning of the meeting, Amanda Cooper, I believe, is now the new finance director for the Area Development District, and so
Yes.
she is taking Chris Corba's place, and will be the ads voting member. So welcome, Amanda.
Hi, thank you.
Okay. Anything else from anybody?
Only thing I have is Edith, it was good to see, not see you, but hear from you again. And everybody stay safe and warm. Check on your neighbors. Don't get out unless you have to.
Thank you. It was nice seeing you again.
There, you got to see her.
Yeah.
Don't hold on.
Take care, everyone. Have a good weekend.
Thank you.
Thank you
Thanks,
all.
everybody.
All right.
Bye-bye.
Thank you.
If there's no further items, we'll adjourn the meeting. Everybody have a good weekend.
Thank you. Thank you.